The Vereckei algorithm is a specific diagnostic protocol used in ECG to differentiate between ventricular tachycardia and supraventricular tachycardia with aberrancy. It was developed as a simpler, often more accurate alternative to the traditional Brugada criteria. It specifically focuses on the morphology of the AVR lead, which is often overlooked in standard rhythm analysis. The algorithm is designed to be followed sequentially. If any step is met, the diagnosis is VT and you stop. If not, you proceed to the next step. Initial R wave in AVR. Look at the very beginning of the QRS complex in lead AVR. If there is an initial R wave, a positive deflection right at the start, it is VT. Rationale: in SVT with aberrancy, the impulse typically travels away from AVR, leading to an initial Q wave. A primary impulse starting in the ventricles often moves towards AVR. You may recall that AVR is towards the right shoulder and ventricles are lower down. Initial R or Q wave more than 40 milliseconds. If there is an initial small R or Q wave, measure its width. If it is wider than 40 milliseconds, one small box, it is VT. Rationale: ventricular origin beats move slowly through the myocardium initially, creating a wide initial deflection compared to the rapid conduction of the His-Purkinje system. Notching on the initial descending limb. Look at the downward stroke of a predominantly negative QRS in AVR. If there is notching, a jagged or shaggy appearance on that initial descent, it is VT. Ventricular activation velocity ratio VI by VT less than or equal to 1. This is the most technical step. You compare the voltage change, ventricular activation velocity ratio, during the first 40 milliseconds, that is VI, and the last 40 milliseconds, that is VT or terminal, of the QRS complex. That will correspond to the ratio of the vertical excursion in millivolts recorded during the initial and terminal 40 milliseconds of the QRS complex. If the initial ventricular activation velocity is less than or equal to the terminal velocity VI by VT less than or equal to 1, it is VT. If the initial ventricular activation velocity is faster than the terminal velocity VI by VT more than 1, it is SVT. Why use Vereckei over Brugada criteria? While both are highly effective, many clinicians prefer the Vereckei method for few reasons. Single lead focus. You need only look at lead AVR, whereas Brugada requires looking across all precordial leads V1 through V6. Speed. In emergency settings like an emergency room or critical care unit, analyzing one lead is often faster. Accuracy. Some studies suggest the AVR only approach has higher specificity for identifying VT in patients with pre-existing bundle branch blocks. Always remember the golden rule of ACLS. If patient is unstable and has a wide complex tachycardia, treat it as VT regardless of the algorithm. These tools are best utilized when the patient is hemodynamically stable and you have the time for a detailed 12-lead analysis. The original reference for the Vereckei algorithm actually consists of two primary papers. While the term is most commonly associated with the 2008 AVR only version, it was preceded by a 2007 multi-step version. The AVR only algorithm most commonly used is the 4-step protocol we discussed, focusing exclusively on lead AVR that is widely taught today. The reference is given here. This study demonstrated that a single lead AVR approach was superior in accuracy to the Brugada criteria, primarily because it eliminated complex morphological interpretations in precordial leads. Here is the reference for the original multi-step algorithm. Before the AVR-only version, Vereckei and colleagues published a broader algorithm that included AV dissociation and other morphological features across the 12-lead ECG. The key finding in that paper introduced the VI by VT ratio, ventricular activation velocity ratio, as a concept which later became step 4 of the 2008 AVR-only algorithm. Here is a brief comparison of the two papers. Leads used in 2007 full 12-lead ECG, while in the simplified 2008 paper AVR only. Step 1 was search for AV dissociation in 2007 paper, while in 2008 paper it was initial R wave in AVR. Step 4 was VI by VT ratio in any lead, while it is VI by VT ratio in AVR for the second paper. Primary goal of the first paper was to improve over Brugada criteria, while the second paper was to simplify to a single lead. If you are citing this for clinical guidelines or an exam, the 2008 heart rhythm paper is usually the one intended when people refer to the Vereckei AVR algorithm.